Only up to signal came. Signal came, but let's see if it connects. फिर से मुझे कनेक्ट करना पड़ेगा ना, तो फिर से एक लिंक भेजना पड़ेगा। नहीं सर, शायद मुझे चेक करना पड़ेगा। चेक स्टूडियो 2 है ना, स्टूडियो 2 हाँ, स्टूडियो 2 पे, स्टूडियो 2 पे वही मैंने तरीका बताया ना, लाइव। हाँ, अभी लाइव आया नहीं होगा, अब आएगा लाइव। एक स्लाइड पीछे कर लेते हैं सर, और क्या करें। स्टार्ट कौन सा नीचे, मैं क्लास में हो गया स्टार्ट। एक सेकंड, ये तो वही चल रहा है। हाँ, स्टार्ट हो गया। हेलो, हाँ आ गया। सॉरी सर, नेटवर्क मेरे हाथ में नहीं है, क्या सॉरी सर, क्या कर सकते हैं, नेटवर्क का मेरे कुछ हाथ में नहीं, सेफ से बोला भी नहीं, वो सर्विस प्रोवाइडर की तरफ से प्रॉब्लम आ रही है। क्वेश्चन पूछा था क्या, किसी का पिन का स्टार्ट कर सकते हैं? हाँ स्टार्ट करिए सर, आप एक स्लाइड पीछे कर लीजिए मेरे ख्याल में। हाँ ठीक है, यहाँ से कर लीजिए। मैंने क्या पता लोगों का पहले से डिस्कनेक्ट हो गया ना, तो एक दो स्लाइड पीछे कर यहाँ से। कितने से कर ये था प्रदान पूरा हो गया था इंटरप्रिटेशन? नहीं, मेरे को लगता है एटलीस्ट एएफएसटी वाला पार्ट फिर से प्रोसीजर है। हाँ, दैट once you got the colony, what you do? I got the diagnosis. I got the diagnosis as a candida torticollis by CMA, and so I did AFST by microbial dilution method. For AFST, I took Candida cruzi ATCC strain 62858 and Candida parapsilosis ATCC strain 22019 as a controls, and I take for microbial dilution I took RPMI 1640 broth as a culture media. So I did in 96 well microtiter plate, that is U-shaped bottom, and initially I added 100. So for working drug solution I prepared for amphotericin. I have to check the highest concentration is 16 microgram, so I took double the concentration as 32 microgram, and voriconazole and itraconazole also same. And Caspo and Mica, the highest concentration is 8 microgram, so I took double concentration 16 as a working concentration. For fluconazole, I need 64 microgram as the highest concentration, so I took 128 as a working concentration. Then I added RPMI 1640 or 100 microliter to all the wells except 12 series, 12th column. So I added 200 microliter into the 12th column because that is acting as a media control. After that, I added drugs and I diluted, I double diluted them. And after that, I added 0.5 McFarland unit of inoculum, that is 50 diluted first as a 50 dilution. After that, I did the 28th dilution. So the concentration of organism is 0.5 to 2.5 into 10 power 3 per ml. So I added to all the wells and the 100 microliter of inoculum. I added to the till 11th well. So 12th well is a media control and 11th well is a growth control. 11th well doesn't contain any drugs. So after that, I incubated them at 37 degrees Celsius for 24 hours. After 24 hours, I interpreted by using the criteria, that is 5 scores: 0, 1, 2, 3, 4. 0 is optically clear, that is no growth. We have to compare this with growth control. And 1 is 70% reduction in the growth as compared to the growth control. And 2 is 50% reduction as compared to the growth control. and 3 is 25% reduction as compared to the growth control, and 4 is there is no reduction in growth. So here for yeast, for candidal yeast, we have different we have uh, interpretation like for amphotericin B, there should be the 100% reduction in growth, that is 0 score. For other drugs, there should be less 50% reduction score, that is 2 plus. For amphotericin B, for sensitive, it should be less than or equal to 1. So I got MIC value as 0.25, so this is sensitive. For caspofungin, for sensitive, it should be less than or equal to 0.250. So I got as 0.125, then sensitive. For micafungin, it should be less than or equal to 0.025, I got as MIC as 0.015, so it is sensitive. For fluconazole, it should be less than or equal to 2, so I got 2, so it is sensitive. And oriconazole and itraconazole, it should be less than or equal to 0.125, I got 0.06 for both, so both are sensitive. So the given organism, that Candida tropicalis, is sensitive to all the drugs.
So in candidemia, if you have the Candida tropicalis, what is the drug of choice you can give to the patient?
The drug of choice is the echinocandins group of drugs. So here, like caspomycofungin and anidulafungin. The doses for caspofungin, 70 mg per day is the loading dose, and followed by 50 mg per day is the maintenance dose. For mycofungin, it is 100 mg. It is a 100 mg is a dose for maintaining also, and anidulafungin, it is 200 mg per day is a loading dose, and 100 mg per day is a maintenance dose.
But it depends. The treatment depends upon the patient.
Whether it is
not for every patient you are going to give caspofungin. So based on the ITSA guidelines, where will you start caspo? And if not caspo, what is the other alternative, especially in resource limited settings?
If the patient is clinically stable, and if the patient is sensitive to fluconazole therapy, then we can start with the fluconazole. Dosage 400 mg. 400 mg. Then if
How long will give?
Treatment, we should actually we have to do the blood culture for every 24 to 48 hours. If the patient become negative, from that 2 weeks we have to continue the treatment. From negative, 2 weeks we have to continue the treatment.
That is if there is no evidence of
dissemination.
So whenever there is blood culture positivity, we always advise some investigation. What is that? There is one investigation which is advised whenever there is blood culture positivity.
To know that it is not dissemination.
We have for neutropenic patient, we have to do ophthalmological examination within the week of diagnosis. This is for non-neutropenic patient. For neutropenic patients, we have to do the ophthalmoscopy examination once the patient is recovered from neutropenia.
So, what is the significance of doing a fundus?
If there is any vitreal opacities or any retinitis, then it indicates that the dissemination is
beyond the bloodstream. And what effect will it have on the treatment then?
We have to continue the treatment.
So you can't stop the treatment at 14 days. Once the culture is negative. If there is dissemination, then you have to keep on treating the patient till the patient is clinically improve on radiological evidence, even
the lesion, ophthalmological lesion.
Yeah. So if at all, supposedly your patient was started on caspofungin, and there was on fundus examination, there was evidence of there was cotton ball appearance. So will you still continue giving caspofungin?
If the patient is susceptible to fluconazole, then
the patient is already on caspofungin. Will caspofungin take care of the intravitreal infection?
No, sir. Penetration is
go back to the penetration. Echinocandins don't penetrate the CNS, the eye, and your lower urinary tract. So you will shift over to
fluconazole. Fluconazole will penetrate all the three, but oriconazole won't. In urine, it won't be excreted. Only CSF and vitreous, it will be. Concentration is high.
So, if at all your species was Candida cruzi,
Yes, sir.
supposedly you had isolated Candida cruzi, what change in therapy would have been?
For step down therapy, we had to use voriconazole as a drug actually.
Yes, so that is important because cruzi
It
is
is intrinsically resistant to fluconazole.
Okay, so initially you can give gastrocontin, but for
Step down
changing to a oral therapy or step down, you can shift over to a
Voriconazole.
So, can you name the CNSI documents that we use in mycology for different antifungal susceptibilities?
Yes, sir. For yeast microbial dilution, we are using M27A4. For filamentous fungi microbial dilution, we are using M38A3. For yeast diffusion, we are using A55, A44, and for filamentous fungi distribution 51, and for ECOF values M57.
57 or 59?
57.
Fine. So Dr. Rosaline has asked, microscopy in culture is adequate for identification or any other thing is required for identification?
So microscopy and culture and Conway agar is also for identification.
Final identification.
Final identification by moldy.
Final, here in our institute we are doing it by Maldito, but otherwise any final identification is by?
Any biochemicals you can put.
Sugar assimilation.
Okay. Or by DNA sequencing,
Yes,
that
sir.
would final again if you have to do. So what are the methods of, if you have a yeast and you want to perform multitof, what are the various methods of extraction of the protein?
Two methods, one is on-plate method, another one is off-plate method. For on-plate method, we are using on the moldy plate. We are taking the colony with the use of that stick.
Okay.
Then we are adding the formic acids. That will break down the yeast and release the material from inside.
Okay.
For off-plate method, mostly we are using here for mold and nocardia.
Okay.
So and for also for any yeast, it is not giving result in on-plate method. For also we can use. For yeast which is not giving result in on-plate method, for that also we can use off-plate method.
Okay.
So in off-plate method, we are using that ethanol glass beads and acyl nitrate and formic acids.
Acyl nitrate? Acetonitrate.
Acetonitrates.
So what is the purpose of formic acid? What is the purpose of acetonitrate?
Formic acid, which is release a breakdown and release the material from the yeast cells.
Okay. Lysis.
Lysis.
And acetonitrate? That helps to separate out the protein component. So that acetonitrate will be separated out. Okay.
So immediately, if you want to give sensitivity, is there any other way to do the sensitivity to give early? Because microbial dilution that takes time. So if you want to give early, then any other method you can do in the lab.
Actually, this from primary sample also we can do, but it is not indicated. It is not indicated if we are doing primarily from sample. Then if we have to check the microscopy if this is a only single organism is shown, and we have to give this as a preliminary. Then after that we have to confirm with the standard method if we are doing primarily from sample sensitivity. And
primary FST is not very standardized for these. It's not like urine that you can directly do. That is, but here, not very often you will read about primary sensitivity for fungi.
And then another method is sensitive titer method.
Because other than CLSI, do we have any other method?
Yes, ma'am. We have epsilon metry method, sensitive titer method, sensititer method. Then Vitek also.
Okay.
Then flow cytometry method.
Maybe flow cytometry is not in routine use. You can tell various commercially available platforms. So you said one is Vitek, you use Vitek.
Yes,
Na?
sir.
Whenever there is a yeast from blood or any sterile fluid, just for a short turnaround time, we give the report on Vitek.
Yes,
And then we later on confirm with the microbroad solution. And sensititer, what is sensititer?
Sensititer is depends upon the color change, sir. Actually, it contains drugs and medium, but we have to add the growth inoculum into that.
So dried up. The drug and the indicator is dried up in that. So you just need to add the inoculum and then it gets reconstituted.
And it will change the color.
So what indicator is used in sensititer?
Sensititer is bromothym.
No. Alamar blue.
Bromothymol blue is used in?
Bromothym OF test.
It is used in antifungal?
Antifungal phenol red is used in RPMA medium with phenol.
M44? Disc diffusion?
Yes, ma'am. Disc diffusion is 0.5.
In the agar. So why do we put
for identifying the exact margin of zone of inhibition.
it is bromothymol blue one of the indicator so that it gives a clear cut margin.
What is the disadvantage of this white tape for echinocandin? White tape is faster than microgrowth, but what is the disadvantage of putting antifungal in white tape for echinocandin, especially for echinocandin?
For echinocandin, we are actually measuring minimum effective concentration.
Does Vitek give MICs? Whatever report you get on Vitek, are those MICs?
MICs one.
So just breakpoints are there.
Yes.
General breakpoints, accepted breakpoints say you get the 2-3 dilution below and above.
Yes,
you don't get the entire MIC range. So that is one of the disadvantages. Vitek, it is said that if it is sensitive, maybe you can release the report, but if it's resistant, it's better to confirm by microbroad dilution and then release the report on Vitek.
Okay.
What are the drugs which are CLSI recommended drugs for disc diffusion of yeasts?
For disc diffusion, fluconazole, oriconazole, and cascophone.
Okay. How much
fluconazole? 1 microgram per disc.
Fluconazole?
For oriconazole, it is 1 microgram per disc.
Fluconazole, what is the concentration of the disc? It's not 1. And what about the echinocandin? Five micrograms. And oriconazole it is?
Oriconazole 1 microgram.
Fluconazole it is
10.
10 micrograms.
And what about the microbroad dilution for how do you, in comparison to yeast, how do you read, the echinocandin susceptibility for molds?
For mold, we have to use the microscopic interpretation because this will echinocandin will change the mold into the compact filaments. So we have to assess by microscopic conditions.
For echinocandin,
the minimum effective concentration we call for echinocandin.
What is the mechanism of action of echinocandin?
Echinocandin that will inhibit the beta 1,3 glucan synthase enzyme, so it will inhibit the cell wall synthesis. It is also called penicillin of antifungal drug.
Next case.
The case 2, the 50-year-old female with complaint of fever and cough for 15 days, and chest X-ray which shows multiple cavitary lesions, and we have received the sputum sample for that patient. So in that direct microscopy, that is KOH fluorescent microscopy, we have seen aseptate hyphae, but septate hyphae also was seen, but in this picture we cannot see clearly. But both aseptate and septate hyphae was seen in this direct examination. From the growth, I did LPCB mount. In LPCB 10x, the low power, we can see the aseptate hyphae with sporangium and sporangiospores, and we can also see the rhizoids, and branching also is there. So because of there is a branching and round sporangium and sporangiospores and rhizoids, so we can interpret this as a, because here there is a rhizoids are there, and an aseptate hyphae with round sporangium, and branching also is there. So we can conclude this as a rhizopus, because this is a size is smaller than the Rhizopus arisus, so it can be Rhizopus microsporus.
Okay. Dr. Nishata said, please describe the growth.
Growth is like in upwards, I can see the cottony.
First, which media was it?
It is a SDA with SDA with micacin, and I can in upwards I can see the cottony growth with it is filling the tube with the salt and pepper appearance.
Okay.
In reverse, it is tan.
It's a tan. So, morphologically, what are the various structures that you look for when you make a lactophenol cotton glue mount?
So we have to see whether it is any hyaline, hyphae is hyaline or demeticious, and we have to see for whether it is septate or aseptate hyphae, and we have to see for that conidiophore or sporangiophore, and we have to also see for the vesicle in case of aspergillus. In case of mucorales, we have to see for the collarete and columella. Collarete and columella, and also sporangiospores in case of mucorales, conidiospores in case of aspergillus.
Dr. Nishat is asking, how many days growth was this?
So this is 3 to 4 days.
So when you're describing the growth, actually you must, in addition, always say that how many days incubation that growth was. Okay. Especially in fungi, because it can be a long incubation, it's better to describe. So how did you identify that this is Rhizopus microsporus?
In high power, actually for we have the sizes, we have to compare the size of the Rhizopus microsporus with the Rhizopus arisus. For Rhizopus arisus, the conidiophore size is like this length is from 500 to 2000 micrometer. For microsporus, it is less than 500 micrometer. And sporangium size also, it is less for microsporus, it is around 250 micrometer. For arisus, it is 500 micrometer. And here we can see this full structure in the single field in 40x. So, but we cannot see the full structure, that is sporangiophore and sporangium in single field. It is in Rhizopus arisus usually long, and we cannot see the whole structure in the single field.
Is there any temperature difference?
Yes, ma'am. For microsporus, it can grow at high temperature till 50 degrees Celsius.
And Rhizopus?
Rhizopus? It is still for 42 degree.
Okay. So which species does not produce rhizoids?
Mucor won't produce rhizoids. Mucor and Apophysomyces. Apophysomyces produce.
Apophysomyces
produce.
Mucor genus is the only one which does not produce. rhizoids. And which important genus, produce apophysis?
Apophysomyces and Clickthymia.
Because that's important, that is how you will identify. So,
how will you differentiate apophysis and leukemia?
Leukemia has more branching as compared to apophysomyces. Apophysomyces, it doesn't have branching, and in both are having rhizoids. In the collarate will be like bell shaped in case of like apophysomyces, but it is
collarate. Collarate, vesicle.
Vesicle is semicircle, sir, and sporangium is pyriform in shape.
In
both have the pyriform shaped sporangium.
Typically, there is some word mentioned that epiphytomyces has that champagne glass appearance.
Champagne.
Epiphytomyces has champagne glass, whereas leukemia is more, bell shaped or funnel shaped.
Yes,
so that is important. Plus, there are those knob-like structures in leukemia which you see, but you don't see it's mostly flattened.
Yes,
there is no protuberance of that vesicle into the sporangium in apophysomyces. So can you name a few species of apophysomyces?
Apophysomyces elegans, Apophysomyces variabilis.
Nowadays, variabilis is
next
more
to
common. More common in Indian setup. If it's variabilis is the most common. Okay.
What about the actidium? Which one is sensitive and which one is resistant?
Cryptococcus is
out of these, leukemia and apophysomyces.
Because from primary growth, if there is no growth in actidium, then you say this can be the.
That is actually very important. In routine reporting, if you have a fluffy growth which is non-sporulating, you almost make the diagnosis that this must be this only.
So I will check.
So Dr. Nishat has asked a question: how will you maintain a stock culture of rhizopus?
For stocking, we have glycerol stock at -80°.
What percentage of glycerol do you use?
10%.
10. There's a lot of variation, but yes, 10%. Some people even use 20%. So, whenever you are maintaining a stock, there are a few points which you need to bear in mind before stocking. So, what are those points?
So we should not use cotton or for clothes.
Starting from the subculture.
Culture. So if you get a culture, what important things you need to remember before stocking it?
We have to have isolated colonies.
So you have to
subculture. If any.
So number one is it has to be a pure
colony.
Then number two. It should be very well sporulated. There is no point of stocking just the hyphae. So because recovery won't be there then when you subculture it from the glycerol. So the more spores, the better it is. So basically you have to stock the spores. So you have to induce sporulation sometimes. Then what are the other methods? One was stocking at 10% glycerol at -80.
Better method is the freeze drying. Freeze drying.
Okay. What is that known as? What is the method, scientific word for that?
Lyophilization.
Lyophilization. Okay.
And other methods like water culture also.
Water culture is not a method of stocking. Water culture is a method of inducing sporulation, especially in apophysomyces and succinia. Other method of stocking or maintaining a stock culture.
And repeated subculture.
Okay. Okay.
That water, no? Water you can put the spore and keep it at room temperature. But that is not called water culture.
That is, you can put the spores in double distilled water, double autoclave, double distilled water. You just keep them at room temperature. So that keeps for years together if it doesn't dry.
Which all doesn't sporulate? Which all species doesn't sporulate among all these pathogenic ones?
This in SDA.
No, yeah, yes.
In SDA, that Apophysomyces won't sporulate, that needs Apex dogs medium for sporulation.
And any other?
Apophysomyces and Saxinia.
Vaccine.
So this was a case of rhinobitocerebral mucormycosis.
No, sir, pulmonary
Pulmonary
mucormycosis with Aspergillus co-infection.
How will you manage the patient?
We had to manage the patient with amphotericin B, because if we start voriconazole, then this is contraindicated in case of mucor infections,
Because voriconazole doesn't act on
mucorales.
Okay. So
Amphotericin B,
which form?
liposomal
Which formulation is used?
liposomal amphotericin B,
How much is the dosage?
3 to 5 mg per kg.
How much maximum you can give amphotericin B in case of mucormycosis if you want to treat aggressively then?
Till 8 to 10 mg per kg. Then we can give posaconazole split therapy also.
What is that?
200 mg 4 times daily or 400 mg 2 times daily.
What are the formulations of posaconazole that are available right now in
It's
India?
oral suspension. Oral suspension.
That's the only formulation available now. Now you have all. Mylan has come out with that sustained release tablets. Then you have even IV, Glenmark and Cipla have the IV posaconazole available. Now all the three formulations are available. Because suspension has one major disadvantage is that the absorption is very, very erratic. You can never be sure of the therapeutic levels. So, which antifungals require therapeutic drug monitoring?
For therapeutic drug monitoring, we for triazoles like voriconazole, posaconazole, and fluconazole also needed, but in case of hemodialysis, hemofiltration.
Oh, generally, fluconazole has, it has linear kinetics. It does not require.
And flucytosine also needed.
Itraconazole. You're talking about is also itraconazole, voriconazole, posaconazole. All three require TDM. Then flucytosine. Okay.
Why not amphotericin B? Why all these azoles also required, and why not amphotericin B?
That's an important question. No? Why aren't we doing it for amphotericin B and even for echinocandins? So again, you'll have to go back to PKPD of these both drugs. So you find out and please make the answers and send. Dr. Nishat has asked a question. What are the other predisposing factors for infections with mucormycosis?
For mucormycosis, it can occur in both immunocompromised and immunocompetent patients. And in immunocompromised in India, the most common is diabetes with ketoacidosis. And next is hematological malignancies, solid organ transplant recipients, and hematopoietic stem cell transplantation, and steroid patients on steroids.
Okay.
And for immunocompetent patients, trauma patients, burns, and patients on hemodialysis with desferrioxamine therapy.
What type of trauma?
Road traffic accidents.
Because there has to be dirty wound has to be there. There has to be contamination with soil.
And also this cotton tongue depressor also it is reported.
There are case reports. Okay. So there it can be. And even in post-surgical wounds.
Yes.
So if your environment has that. Fine. So any newer drugs you know of? Newer antifungals which will be useful for mucormycosis in addition to, because right now we only have amphotericin B and posaconazole. Are there any few new drugs in the pipeline which will be useful for management of mucormycosis?
Azoles or any other?
Isavuconazole.
Okay, isavuconazole.
I will check.
There are 3-4 new drugs coming up in the pipeline.
Ifrexafung.
Ifrexafungal. Fosmanogepix. These are two important drugs which will be useful for management.
Sabuconazole is what is the form available for the patient? Which form?
IV formulations and oral formulation.
Oral also. Oral also is available. That's the advantage actually. Both this for sabuconazole and sabuconazole oral formula.
What do you understand by breakthrough mucormycosis?
So then, if you start voriconazole therapy in
So any patient, supposedly yesterday I started a patient on voriconazole and today the patient has mucormycosis, will I label the patient as breakthrough mucormycosis? Why?
so after 48
48
Yeah.
hours. Especially if you are, sorry.
There's a definition for the.
Yeah. So you read up the definition. Basically, general concept is whichever drug is causing that breakthrough, so that drug should achieve steady state. Voriconazole achieves steady state at an average of 5 days. So basically after the 5th day of starting voriconazole, if you have mucormycosis, you generally label it as breakthrough mucormycosis due to voriconazole. Not earlier than that, because the levels haven't been achieved in the serum to cause a breakthrough infection. So there is a whole article on breakthrough fungal infections. So you go through that. It's important when to label breakthrough mucormycosis.
So in your case, patient was taking voriconazole beforehand, or they have not started antifungal only? Because you have two types of infection, no? Mixed infection.
history is not actually patient is history.
What are the scenarios where you will have two fungal infections in the lung? Generally, we don't have. But what predisposing conditions will be there which promote two infections, or which where you very often find two infections?
Preformed cavities.
So preformed cavities are so basically the aspergillus might be there pre-existing in that cavity, and then because of the predisposing factor or chemotherapy or steroids, then the mucor comes in. So the aspergillus is already there in the cavity.
Any other cases?
In bone marrow transplantation and hematopoietic stem cell transplantation.
Mixed infection. Aspergillus plus mucor, what will cause both of these to come?
COPD patient also you can get.
And critically ill ICU patient.
ICU patient. Or allergic maybe. Allergic, if they have the aspergillus, so that will be like colonizer only. And those patients can get, like if they are diabetic, so those patients can get mucor.
Thank you, sir. Thank you, ma'am.
Dr. Nisha.
उसको allow करते हैं, एक बार में तो allow नहीं करते हैं।